Hi, it's Dr. Centeno, and thanks for joining us today. You've got the power. We're going to be talking about an interesting topic today, the lateral AO ligament. And as usual, go over that. And then after that, I can answer questions about that topic or really any other topic. So again, today we're talking about the lateral AO ligament, or the ligament that attaches the outside of C1 or the atlas to the skull, and what its implications are for craniocervical instability. Let me go ahead and start by sharing my screen. Looks like that worked. We'll get the lateral AO ligament up there. So again, today we're talking about the lateral AO ligament. You can see that. I'm going to show a lot of different pictures of it, but you can see it right there in red and right there in red. This is the skull way up here. And this is C1, C2. So just have a sense. So you have a sense of where this lives. This is the most recent study that I could find on this topic. Shane Tubbs has done a lot of these upper cervical ligamentous anatomy studies. And so they did an investigation here of this ligament specifically. And what they found was that it was in all specimens. So that's good, because some of these more or these smaller ligaments are in most people, but not in everyone. So they found it in everyone they looked at. The ligament resisted lateral flexion, which is lateral bending. It makes sense. And also rotation of the lateral occipital joint. So that's the C0, C1 rotation that I've talked about previously. And this is just from Shane Tubbs' paper. I'll show a couple different pictures of this. This is the skull. This is C1. This is C2. And you can see that it comes from this lateral transverse process of C1. And it goes from C1 up to the skull. And so make a lot of sense. For instance, if we try to move the skull that way, this ligament, the lateral AO ligament, is going to resist that. Also, if we try to twist the skull on C1 or that C0, C1 joint, this lateral AO ligament is going to resist that as well. And this is another view here. This is AO ligament in yellow, AO ligament in yellow. Again, just to orient you, this is C1, this is C2, this is the skull up here. Pretty important to realize that the vertebral artery is snaking through here. So there's a little foramen or hole in C1 where the vertebral artery goes through. And one of the problems with injecting this ligament is you need to make sure you're not in the vertebral artery, because if you are, that's a bad day for everyone. That can cause a brainstem stroke. So this is one of those ligaments that needs fluoroscopy with digital subtraction angiography, just like injecting the C0, C1 joint there or the C1, C2 joint there. You need to make sure that you're not in that artery before injecting. And this is the subtyping system I put together for CCI. So really, we're talking about these type 1s or these type 1 instabilities when we're talking the lateral AO ligament. And those are instabilities between C0 and C1. And so we're talking about translational instability here, whether that's front, back, or side to side, where we see this sliding of 0 on 1, often due to the very shallow or abnormally shallow C0, C1 joint. Also, the rotational instability that I talked about before And this is going to be, it should say 0 to 1, but this is going to be the skull rotating on the atlas or C1. And again, should be an A in there, sorry. And so what you're going to see here is this is where that ligament would live. So it makes sense, and there'd be one over here as well. So it makes sense that that would resist the skull rotation on C1. And then this is what a fluoroscopy injection looks like. This is the needle here, a 25 gauge needle. This is the transverse process of C1. And then you can see the contrast going into the ligament there. And this, we put enough contrast and inject it in here, it'll go all the way up to the skull there. Again, we don't want to be in this vertebral artery here. So it's pretty critical that we use digital subtraction angiography to make sure we're not in that area. So in summary, in CCI type 1, we often inject a lateral AO ligament. Again, this needs to be done using fluoroscopy with digital subtraction angiography to make sure the nearby vertebral artery isn't also injected. So let me stop sharing here. It's kind of a short one today, and we'll go and take some questions, see what we got. Andy, is it possible to treat capsular tears at 0 through 2 with PRP, or do you need the strength of BMC? No, you could treat those with PRP. It's probably not going to be as strong as bone marrow concentrate, but you certainly may get some results there. Andy, with C0, C1 rotational instability, which of the 4 sides of the C0, C1 capsule are you treating? You know, a stronger influence on 0, 1 would be that AO ligament we just talked about. So that's the lateral AO ligament, and that LAOA, or the lateral anterior AO ligament, which comes up from the front. So those are 2 ligaments that come off the transverse process like that are going to have a much bigger impact on rotational stability than the capsule. With regard to the capsule, what can be safely injected, you could do the anterior capsule from the front through a PICL approach. You can do the posterior capsule. If you try to get, you could probably do the lateral capsule as well, though you'd have to be very careful not to be in the vertebral artery. And the medial capsule might be higher risk of getting into the dura and injecting intradural. So that one probably not. Dr. P, have you ever had a CCI patient whose only complaint was a feeling of heavy head? No, that would be pretty atypical. So there's usually something else other than heavy head. Dr. P, can atrophy of the deep neck flexors cause a feeling of walking on a trampoline? Usually not. I think what you're describing is general imbalance, and that's normally due to proprioceptive or bad proprioceptive information coming in from 0, 1 or 1, 2. Stefan, hi, Centeno. I wanted to ask you if you might have an idea about what I can do. I'm trying to sleep on my back, but about every 10 minutes I wake up as if I'm jolted by an electrical shock in my body. When I try to lie on my side, I end up turning on my stomach and twisting my head. Do you have suggestions for back sleep with CCI? Thank you very much, and greetings from Germany to your super team. Yeah, Stefan, that's a good question. I think what I'd recommend is probably not sleeping in a bed then. Some patients sleep in a recliner. So I think if you slept in a reclined position, 45 degrees, you're probably less likely to have an issue because you're going to be taking some of that gravity off of the neck, and then it's pretty impossible to sleep on your side in a reclined position. So that'll prevent that from happening. Amen. Centeno, can antidepressants ease the symptoms, although CCI issue is still there? Yeah, there are certain antidepressant medications that work in chronic pain. So from that standpoint, you might have one relieve some pain. Sure, it's not going to be a solution, but it may help with the pain component. Andy, when treating the 0-1 posterior capsule, does PRP spread on the whole length of posterior capsule, lateral, center, and medial? I think you asked that one last week. So in general, it will spread well along the posterior capsule. As to whether or not it gets the entire length of C0, C1 will depend on the patient. And you also need to do a risk-benefit analysis, meaning that there's a certain risk factor even in someone who's done the 0-1 joint 1,000 times or 3,000 or 4,000 times like myself and uses digital subtraction angiography. I don't know that I'd want to enter the 0-1 posterior capsule 3 times. The risk benefit is just doesn't make sense. Andy, do you think pharma will eventually create a drug that can temporarily stiffen and lax ligaments for hypermobile patients? No, I think it's more likely that we'll see a pharma-based genetic treatment at some juncture, and that's going to involve gene editing for patients who are hypermobile. Now, whether or not the focus is identifying that in the womb and doing that in the womb, or whether or not there's an adult treatment available, I don't know. John, for the PICL procedure, are you able to target the insertion of the alar ligaments onto the skull? Yes, not a problem. John, are the alar ligaments stronger compared to something like the ACL on the knee? It's a good question. I think they are stronger than the ACL on the knee. The transverse ligament is reportedly, which is the other ligament going across the dens like a seatbelt, reportedly the strongest ligament in the body. Makes sense. If that ligament fails, you're dead, right? So you would put a lot of resources into those types of ligaments up there, and you'd want to make those as strong as possible. Because if you had people born with weak upper cervical ligaments, from an evolutionary standpoint, they would get weeded out in that a certain number wouldn't survive to reproduce. So I imagine there's been heavy evolutionary pressure on choosing people with strong upper cervical ligaments. Centeno-Schultz, advanced by Lionel Schwartz. Is there anything we can do to keep our neck stable or saving money if the travel involved from Europe for your procedure? I think avoiding things that aggravate your condition is a good one. You can also wear an intermittent cervical collar and do that only when you're in situations where it's going to flare you up, and not for more than a half hour a day. So you can use that judiciously. AT, how long do you believe someone should undergo CBP, upper cervical chiro, before considering a PICL? Do you require someone who's tried posterior prolo before considering someone as a PICL candidate? So I would give that a good 3 or 4 months. Now, people are going to pretty quickly fall into one or two categories there. In my experience, they're going to pretty quickly come to the conclusion that, wow, that makes me feel really good. Maybe it doesn't last. If it doesn't last, you'll know by that 3 or 4 month mark. Or for some patients, it's just not a good fit for them, or the vectors aren't right. As far as posterior prolo goes, no, we don't require that before a PICL. If we've got certain types of CCI that are more likely to do well with a PICL procedure. Eamon, is it possible for a healthy 23-year-old male to have rheumatoid arthritis symptoms all of a sudden? Sure. Yeah. I mean, certainly you would want to get checked out for rheumatoid arthritis. Realize that rheumatoid arthritis can affect the upper cervical spine, but that's usually as rheumatoid arthritis patients get older, not real common in rheumatoid arthritis patients in their 20s. It's been advanced by Harry Winston. How long is it safe to be on a very low, no carbohydrate diet in preparation for the procedure? Indefinitely, meaning there's no problem being on a low, no carbohydrate diet. It's hard to get no carbohydrates. It's probably easier to get low carbohydrates. That's the way our ancestors ate. Sugar is a relatively recent invention, as is agriculture and grain. So our ancestors, they ate a very, very low carb diet. In fact, they'd probably only get exposure to higher carbs during certain times of the year, when fruit was available, berries, things like that. And even then, that would have a fraction of the sugar and carbohydrate load of what we all get experienced or exposed to. Strange, hydroxy, how does intubation and surgery from other health reasons, not CCI, affect your progress post-PICL? Well, intubation can be a tough one because, you put a ET tube down, oftentimes by using a laryngoscope. So a laryngoscope, we're taught to put the laryngoscope blade on the top of the roof of the mouth and suspend the head with the blade, and that opens the airway to get the ET tube down, and so that you can see that you're going in the trachea and not the digestive tract. So that would be a tough one on the upper cervical spine. Bethany, how Centeno you found a swollen burst at 0-1. I wonder if it could be because of a damaged AO ligament. With this, just I have type 1D. I believe I have type 2B with overhang of 4.5. I'm 4 months out. Post second PICL, still waiting for improvement. Would my AO ligaments have been injected? In all likelihood, Bethany, I don't know. Again, I think as we've talked about before, you've got a really big issue going on in the lower neck that probably needs to get handled one way or the other for anything really to work. Ulysses, is it safe to inject saline prolo in the neck or just dextrose? Well, dextrose prolotherapy is usually made from some sort of dextrose, some sort of anesthetic, and saline. There is really no such thing as saline prolo per se. There has to be something in prolo to make it hypertonic. So that wouldn't just be saline. There has to be something else in there to have it cause a brief inflammatory reaction. AT to follow up, I've been working super hard with CBP rehab. I have severe CCI at 6.3, right, 3.8 lateral flexion. I was able to improve on the right side 1 whole millimeter in the course of the past week. That's great. Yeah, I think that to the extent that we can get the curve back, that's going to take forces off those upper cervical ligaments, and by all means maximize conservative healing as much as possible. There's certainly no reason to do anything else if you're improving with just CBP. Regenetics been advanced by DB. Can upper cervical disc issues mimic the symptoms of CCI? The headache component for sure. So the C23 disc can refer to the head. Dizziness, probably not. Imbalance, visual issues, probably not, but certainly the headache component. Jim, this response to Duck's comment of feeling of walking on a trampoline might improve 89% from tracing designs with laser pointer JPE laser tracking for 4 weeks. Yeah, Jim, you bring up a good point, and that is if you are one of those people who can strengthen the upper cervical muscles using that type of laser pointer training, and we've got that online if you want to use ours, if you want to see a physical therapist that can walk you through it, either one. But by strengthening those muscles, you may be able to reduce that imbalance sensation, because realize that imbalance sensation is coming from bad position sense information from the upper cervical joint, 0, 1, 1, 2, 2, 3. So if you get better muscular stability there, that may be all you need, which is obviously the best of all worlds. Regenetics been advanced by DB. Can CCI cause emotional issues? I mean, we certainly see that it can cause fight or flight response. So that's associated obviously with some emotional component. So yes, it can cause that fight or flight response by irritation of the vagus nerve, a reduction of that parasympathetic input, and then an overdrive of the sympathetic fight or flight response. John, what's the best piece of advice you can give for young teenage hypermobile people to prevent damage when they get older? Yeah, probably don't do this all day. And it's not just EDS patients, it's all younger people. I mean, if you're going to be looking down your phone all day, that's awful, meaning that there's probably nothing worse that you could do on a long-term basis for your spine other than maybe other than riding broncos or getting thrown from bulls. So that's a pretty awful thing to do to your neck. And we have an entire generation that's doing it, and we're going to have an entire generation with screwed up necks. So this is a phone, don't do this all day because that's going to destroy your neck. John Hull, I know a sports med doctor that has classical EDS. He's got many, many joint dislocations. Any reason why he hasn't developed CCI yet? Yeah, I mean, all EDS patients don't develop CCI, meaning that it's only the ones who end up with enough movement hitting the right things that get symptomatic. And just like MRIs of the neck, right? If we take an MRI of the neck of 160-year-olds walking around in the street, probably half of them are going to have awful looking necks. Probably a third of them are going to have necks that a surgeon would operate on, but none of them have any symptoms. So, not everyone with the same problem gets the same things. John, hey doc, how do thoracic disc protrusions do with BMAC PRP injections? I've had PRP adipose along thoracic facets without much improvement for thoracic disc instability. Do you do them? Yeah, I think there's so the first thing you'd want to make sure of is that you wouldn't respond to something less invasive, meaning along the thoracic facets tells me you're seeing the C team or the B team, meaning that there wouldn't really any reason to put it, quote, along the thoracic facets. You might want to be in the facet joint. You might want to be in the ligaments, but there's also around the nerve or epidural there. So it sounds like the first thing you've got to do is to sort of get to the point where you get some good thoracic care that's focused on various structures that might be causing issues. And then if you fail that, you can always inject the disc. It's just higher risk. And if the goal is to try to get rid of the protrusion, we've got less data on that in the thoracic spine than we do in the neck or the low back. So leukocyte-rich high-dose PRP intradiscal could help that, mostly if there's pain coming from the thoracic disc. There are other ways to treat protrusions, but they're a grade above in sophistication what you're kind of writing there. Duct P is 13,000 good enough to cover one PICL plus DMX plus hospital visit? Should I wait a little longer and save up more? Yeah, the PICL runs 12,500. A DMX is about $800, I think, $600, something like that. Office visit tends to run around 300 if you don't have insurance. So that's pretty darn close. Stefan, what is the earliest available treatment for PICL this year? I don't have any idea, Stefan. That's something you need to talk to Carla, my assistant, about to see what that is. I know that between now and the time I take my fall trip, I'm pretty sure we're booked other than for cancellations. And we always have at least 1 or 2 cancellations a month. So if you're on that cancellation list, you can usually get on that and get in. Diana, do people with severe central sensitization do worse with PICL? How are they affected? Yeah, it's a problem. And one of the reasons why I think, as I've said many times here, we try to take the less is more approach with that patient population. I mean, we try to do as little as we can out of the gate, get a sense of how they're going to respond, and then do a bit more after that. But yeah, it's a big problem. As far as do worse, no, but you're going to see much longer flare-ups. And there's always the concern of pushing someone into a super long flare-up by doing too much. Duck P, do you know about a device called Halo Posture? A chiro in Kentucky found in the mid-2000s that can reduce C1 to overhang in his patients due to strengthening. Not saying I recommend it. You know, that's not one I've seen, Halo Posture. Let's see what that is. Sounds a lot like the oh god, this is the neck weights and the head weights. Yeah, so I wouldn't recommend this for CCI patients. We've seen more flared up CCI patients due to head and neck weights than we can count. So there's one guy who does some very simple neck injections in Florida that prescribes a lot of head and neck weights, and we've seen just lots and lots of flared up patients from this approach. I think the concept is this is something you can do at home. The problem is that the vast majority of CCI patients aren't ready for it. They might be at some point in the future, but I would say that just looking at it, that's probably a really bad idea for most of the patients that we treat. Ulysses, text neck causes straight neck. Yeah, text neck causes straight neck, causes lots and lots and lots of problems. So again, for you kiddies out there, doing this all day is probably the worst thing you could do for your neck possible. Don't do it. And you got to pay attention to what's going on with your neck, because we're creating an entire generation of severe biomechanical issues in the cervical spine and thoracic spine. Amen. I did grab Oaks and power measurements on my spine MRI, and the results are good. It doesn't show CCI. Can the results change a lot when upright? Power ratio 0.6. Can I get one while upright? Upright can change those measurements, but realize those are static measurements. So I would put them into the low likelihood of showing CCI category. Obviously, CCI or craniocervical instability, or any type of instability, is a movement-based concept. So you need movement in there to show it. So that's going to be movement-based imaging. Duck P, just curious, but do you get professional athletes coming to your clinic for treatment? Sure, yeah, we have a bunch of them on the wall. Most of them don't want us talking about it, but if you come to our clinic, there's, I don't know, 50 pictures on the wall of various athletes, something like that. Chris, how does one know if they have central sensitization? Yeah, so central sensitization patients are those who have huge flare-ups with any kind of procedural or manual care. So for example, while the average person who gets an aggressive massage might feel sore for a day or two or feel better, a centrally sensitized patient might be down for the count for a week or two as a result of an overly aggressive massage. Or the average person gets a neck injection that might be sore for a couple of days. A centrally sensitized patient would be sore for a couple of weeks, that kind of thing. Ulysses, is it safe to treat the skull without treating C0, C1 joint, avoid the vertebral artery too? Well, oftentimes the joint at 0-1 needs to be treated when you're treating any type 1 instabilities. AT is $13K for a treatment plan of PICL or one single injection. No, just per injection, that's what it runs. Jason, familiar with dermatome, myotome maps? Does anything similar exist for the inside, particularly the esophagus? Yeah, we use dermatome, myotomes all the time. As far as for the inside, there are referred pain diagrams. If you just type in online esophagus referred pain, You can probably find some studies where they have artificially stimulated the esophagus to cause pain and then ask patients where they felt it. So that should be available online, but it would be called referred pain. Duck P, well, to avoid wasting your money and getting a possible injury, avoid carrying medical in Florida. There, I said it. You can't treat CSI with useless C1, C2 capsule injections. Yeah, I would probably add some specific thoughts to that. I think carrying is just doing simple posterior prolotherapy. And for certain types of CCI, like 3B, where we're talking about C2-3 instability and flexion, that may be very helpful. But when it comes to the other types of CCI, it's not going to be very helpful in general. So I think it's important to figure out what kind of CCI you have, and then you can see whether or not a simple posterior injection approach like the one done at Caring is a good fit for you. Liam, hi, Dr. Centeno. Have you ever heard of mewing? Mewing is a technique in which the tongue is placed on and pushed into the roof of the mouth in an effort to correct orthodontic, breathing, and fascial structural issues. This actually helps stabilize the head for some CCI patients, reduce symptoms. Yeah, it's interesting that you say that. I've got congenital central canal stenosis in my neck, meaning I was born with a small central canal. I've got a big head on top of that. So I've had 2 times in my life where I had enough dural irritation that all the neck muscles shut down. And putting my tongue in the roof of my mouth is something that would help to stabilize my neck temporarily. And either that or just getting up from a bed by grabbing my hard palate in my mouth and pulling up my head. So I certainly would believe that you could get a good sense of stability. I don't know how long you could keep that up. I've never tried that, but it certainly may be something that helps some CCI patients find that stability when they're having trouble finding it. Amen. We don't have DMX in our country, so I try my best to get similar imaging like mouth, bended head. Yeah, so amen. If you reach out via email, we can get you the protocol we put together. You can certainly give those to a local radiology center and see if you can get them to do that type of imaging. Kim, is it possible to find someone in your local area that you have trained? Not for CCI. No one's been trained for CCI to date. So CCI is a Colorado only thing. That has to do with lots of different things. I think, as I've said here before, the next 3 to 5 years, I'll probably be retiring. And then at that point, I will handpick some people and train them in CCI, train them in PICL, etc. But that's a really big thing to ask those doctors to do, to stop their worlds, their practices, come to Colorado for a significant chunk of time and learn how to do all this. But no, we have not trained anyone in CCI to date. Lissy, have you treated carrying patients, or have you treated carrying medical patients before? Sure, we treat a lot of carrying medical patients. Again, in general, what we tend to see is they tend to have the kind of CCI that doesn't respond to simple posterior prolo. So that's probably why we're seeing them. Mark, I have an issue with my T1 twisting. What ligaments we need to be treated to stabilize the T1 so it won't twist? I'm thinking the intertransverse ligaments and any other ligaments that would need treatment as well. Yeah, Mark, so the first thing you would want to ask, is there scoliosis or side bend of the spine, in which case it makes sense that the T1 twist. But if we're talking about an isolated twisting of T1, the intertransverse ligaments would be tougher to do in that area. You'd probably need to use both ultrasound and fluoroscopic guidance, because the lung is right there and you could inadvertently puncture the lung and put someone in the ICU. You would also want to get the fascial attachments to the T1 spinous process as well. So you'd want to treat one side preferentially, the long side of that fascia that attaches into that area. John, actually putting your tongue in the roof of your mouth activated your deep neck flexors. This is an exercise created by Dr. Stuart McGill. We do this Sure. Yeah, that's one way to activate deep neck flexors, longus coli, capitis, all that good stuff. Chris, I'm also part of the congenitally narrow canal and big head club. Yep. You know, that's that's a real club, regrettably. Mark, do you anticipate any supply issues in Centeno-Schultz Clinic to a tornado? Yeah, it's interesting. I saw that yesterday, that story. So I don't know. We'll have to see. Most of the stuff we get is from McKesson, and I don't know how much stuff they're sourcing from Pfizer there. My guess is probably not a lot. And, thankfully, we have a CGMP air handling lab where we can aliquot larger amounts into smaller amounts in a hyper-sterile fashion. So, the few times we've come up against supply chain issues during the pandemic, which were even more severe, we were able to, for instance, instead of buying vials of dextrose, let's say, because that wasn't available, we were able to aliquot larger bags, those sorts of things. Liam, do you have any advice for type 2B CCI patients who work desk jobs full time? Sometimes it feels like my symptoms are worse at work, despite using a stand desk and a lot of effort on keeping head neutral in all planes. The nature of looking at monitors and keeping head so static is difficult some days. Yeah, Liam, I think I would start to try those eye tracking exercises to see if that helps and see if you can tolerate it. If you can't do that, then I think just an intermittent use of a collar here and there, 5 minutes here, 10 minutes there, that kind of thing. And then obviously it sounds like you've already optimized your desk. James, can you treat upper cervical ligament tears versus stretched? Well, there's tears pretty much in all the ligaments we treat. I think what you're talking about is a complete retracted tear where the ligament is torn in half and pulled back with two ends like a rubber band. So we can't treat that. Fortunately, it's super rare. I've only seen it in a handful of the several thousand CCI patients we've evaluated. So thankfully, it's not at all what's usually seen with these ligaments. Okay, guys, so it's coming up on 40 minutes after. I just got one question here. Amen. Are bone spurs at 5'6", always due to instability or can be from text neck? Yeah, usually instability or what's called degenerative instability, and that's when the disc loses height, things start to move around too much, and the bone spurs form to try to stabilize. Any other questions out there for me on this Friday? I'm going to end a little bit earlier today. I just have a 2 o'clock meeting, so I want to make sure I can get ready for that. Still haven't fed the dog, so I got to do that. Any questions for me? Okay, guys. So what we talked today about was the lateral AO ligament. Here's Fatchin. Shaving C1TP to get rid of the AO ligaments would get rid of the AO ligaments and obliquus capitis. Yeah, so you're right. So I think what Fatchin is bringing up is an important point, and that is that we have some surgeons who have gotten into shaving the transverse process rather than cutting the styloid to try to help and open up that area of the internal jugular vein. The problem with that is that you're probably going to do some damage to these AO ligaments we're talking about. Liam, is jogging a bad idea during PICL recovery, specifically a month in with type 2 CCI? Probably not a great deal or idea, Liam. I think what I'd try to do there is maybe do some jogging in the pool where you could, get right up to here and do some jogging just to really reduce that force coming up through the buoyancy. Ulysses, can you do a needle video on Monday? Yeah, Ulysses, I'm just trying to sort of go through the ones I have already prepared. So not sure if it'll be Monday, but we will get to it. Okay, guys, thanks so much for watching today. You all have a great weekend. I will be here this Monday. And yes, I think I'll be here on Friday as well. Then I've got a lecture on Saturday and a lecture on Sunday, one here in Colorado, one in Florida. But that shouldn't affect the videos going out on the Facebook Lives on Friday and Monday. Thanks so much for watching. Everyone have a great day and have a great weekend.